ear pus, and the patient has seen their GP, they've had an ear swab taken, and they've been prescribed some medication called ciprofloxacin. Ciprofloxacin is sometimes also used as eye drops, and historically they were used for ear infections off-label by ENT doctors. However, in recent times, ciprofloxacin is now made for ear infections as well. They are non-ototoxic, and what that means is some ear medication, if it penetrates through the eardrum, so into the middle ear, it can cause permanent hearing loss. It can then enter the cochlea, the organ of hearing, and it can cause permanent hearing loss. And they're known as ototoxic medication, and ironically a lot of medications that are used for ear infections are ototoxic. So they can only be prescribed when we know for sure that the patient hasn't got a perforation of the eardrum. So quite often if a patient has got an ear infection and a perforated eardrum, so maybe glue ear and there's a perforation and all the discharge is leaking out, so we call that suppurative chronic otitis media. That's the term given for chronic ear infection with a perforation. Ciprofloxacin is just really ideal for that type of infection, but they are antibiotics, so it has to be a bacterial infection, not a fungal or viral infection, otherwise they'll be no good. So I'm just using a fine end. You've probably seen that I'm trying to clear as much discharge as I can, and the patient was advised to come and see myself by their GP so I can clear the ear before using the ciprofloxacin. So these are drops, and what the GP quite rightly was worried about is if the patient puts a drop in, it's one drop a day, it will just get diluted by all this discharge and pus, and it may not do much. So the drier we can get the ear, the better. Now, because the ear is heavily swollen, and the patient was extremely reported some tenderness in the ear, so we be really, really gentle. So I'm just using a fine end suction probe. I can't get a standard size Zollner suction probe into this patient's ear because of the swelling. You can see where I am now. So this is the medial anterior canal wall. It's obscuring most of the view of the eardrum. So that bone on the left-hand side should be much more recessed, but because it's infected, it's swollen, and I can only see the back part of the eardrum, which makes it really, really difficult. Now, I've got most of that discharge out already, all that pus that was deep in the patient's ear. That's all been suctioned out, but now I'm just going back in, and I'm just trying to get as much debris, dead skin as I can possibly out of the ear, but without it hurting the patient, cause patient any injury or trauma. We don't want to make them experience any discomfort. So I'm just gently using the fine end here. You can see I'm peeling some dead skin. Now, the patient has got a chronic history of ear infections. In fact, in their right ear, they've had a previous mastoidectomy. So a mastoidectomy is when the bone behind the ear can get infected. It's a porous bone. Sometimes if you've got an ear infection, glue it can get absorbed by the mastoid bone. You can develop what we call mastoiditis. And because the mastoid bone is underneath the skull, the brain, that infection can spread upwards. In the worst case scenario, it can cause meningitis, a brain abscess, could even lead to death in a really worst case scenario. So that bone has been removed, drilled out in the patient's right ear. So unfortunately, it's the patient's it's growing up as a child. They just had chronic infections, and it's all about managing it. So I'm just using the fine end now. I've had to bend it, the tip of it, to get into this gap. And we're directly onto the eardrum here. And I'm just trying to get as much debris as I can. You can't, obviously there's no sound here, but if the sound was on, you would hear some fluid being suctioned there. So we just want to get it as dry as possible. And you can see we're just at the valley, the base here, and it's just managing to get the fine end in. We don't want to make contact with the bony part of the ear canal. It's going to be really uncomfortable for the patient. And again, I've just bent the tip around the bone, and it's a bit of fluid there. Again, there's no live audio, but if there was, you'd be able to hear the fluid being suctioned there gently. So it's still a bit damp at the top of the eardrum, and just again, you've got to be really careful. I'm going to try and get as much of the skin off now. Some of the skin is embedded, it's not going to come off, but any wet skin that's sitting on the surface. I'm going to try and just peel that. So you can see I've got a bit more out there. I think I'm going to go back in the same area, so just near the roof of the eardrum at the top. And again, I've just bent the tube to kind of bend around this bony protrusion. So this widening here, we're probably looking at no more than 2.5 millimeters. That's how narrow it is. The fine end suction probe, it's probably about I've got to measure, I think it's about 1.4, or is it 1.7? No, I think it's 1.7. And that's just fitting in, yeah, so 2.5 mil opening is about right. Now, the patient's course of medication, I think it's 7 days. And we've invited the patient back, just so it's so difficult for patients here at the moment to see GPs and doctors and ENT on the NHS. It's just overwhelmed the system because of COVID and everything else. So the patient just wants to make sure that the infection has cleared fully and they don't need a repeat prescription. So again, just at the base here, just trying to peel some skin that's just embedded on the eardrum. If I can't get it, I'm not too concerned now because I've dried the ear out. That's the main thing. With ear infections, we want to make sure the ear's dry afterwards. Water's so bad for the ear, guys. I had another lady today that had really severe otitis externa. I'll try and upload the video in the next couple of days. They'll be getting water in the ear, and after I've cleaned up the infection, I was just going through the clinical advice, a management plan with them, and again we've referred them to their GP so they can get prescribed some medication, but I kept stressing the need for the patient to avoid water in their ear, and I think I did drill it home. So that's good, and hopefully that they will avoid that. So water will just exacerbate this infection. So this patient's already aware that they suffer from chronic infections, as I said, and they are very, very diligent and careful. Although they did get some water in this ear back in the summer, they jumped in the swimming pool. And yeah, I know most of us do that, and most of us will be fine. So if you get a sample of 100 people, for example, and expose those 100 people to water, there's going to be a small percentage, I would say 5 or 6%, it may be more, that as a result of that develop an ear infection, and it's hard to predict which 5 or 6% of those people do. In my experience, once someone's had an ear infection, for some reason, despite if you've resolved that infection, they're always more prone in the future to have a reoccurrence. It's just an odd thing. So my best advice is to avoid water in the ear in the first place. So I've really cleaned that out. You can see just got the endoscope around that band so you can visualise the eardrum. I hope you enjoyed that video, guys. It's something different. It shows you some different skills that we have to use. So it's not always earwax. As a clinical ear care specialist, we deal with a lot of